engaged with the required skills, and they are deployed exactly in the right place? Is there a possibility? There is a structured way, pretty simple, that I have a structured flow which says that I am going to nominate certain resources. They are nominated for a particular skill based training, and they'll receive the training from us, and they'll be deployed at the district level. But for how long? Aren't they going to get transferred? Aren't their responsibility going to get shifted to some other department? It is very much possible, and it is frequently happening. So we come across this problem, and how we figured out is that we cannot restrict the knowledge to one individual or some fixed noodles. The knowledge has to flow, and that is why the name Gyan Ganga, because the Gyan flows like Ganga to everybody, and whomsoever wants to attend that session, it is open for all. So with this problem, we have come up with a solution that what we are going to do is we are going to have a continuous learning platform. It is going to be an open platform for everybody. Whomsoever wants to join in, they can join in and they can build their skills. I'm sure that there is a new age idea that there are open mics in clubs, and there are open mic sessions at the restaurant. So whomsoever is having bit of talent, they can showcase their talent. So Gyan Ganga is nothing but an open mic session for ABDM program. What we have done is we have fixed a slot that every Friday 4 to 5 p.m. we are going to have an open session. It is called Gyan Ganga, and whomsoever from the district administration wants to join in can join in. And you will be amazed to know that we have figured out certain resources, or maybe we can call them trailblazers. They come up with an idea, sir, that, sir, I have certain skills and I can present it better than what your team is presenting. So we said that why not? It is an open platform. If you want to present it, be my guest and you can present it. And now we are having trailblazers also from each district. They are presenting on our behalf. What we have done is it is a weekly session, not entirely unstructured, because there are definitely certain structures where we have some fixed sessions, and then half an hour is dedicated specifically for a particular agenda, but half an hour is free for the rest of the team, and even the district resources. If they want to present something, they are also presenting. It is open for doctors, it is open for private hospitals, it is open for my district administration resources. It is even open for if somebody who's an Ayushman Mitra, or who is just associated with any hospital and looking after certain Abha creation drives, they are also open to attend those sessions. So it is a continuously a consistently happening capacity building program across all the district in one go, on a fixed time every week. Next slide, please. So what we are doing is we are having an since we have this connection that we come across multiple districts which are saying that some of the districts are having certain resources. They are trained on the same platform, on the same agenda multiple times. However, there are certain districts, there is no one who is trained on particular skill set. Let's say somebody is no aware about scan and share, but other districts are not having even a single resource. So once we started doing Gyan Ganga sessions, we have ensured that every district is having multiple resources, those who are aware on the single agenda, and they can even present it also. So since it is a regular flow like Ganga, we have guided everybody to have complete knowledge about the ABDM, and I'll be showing the numbers to you that how we have trained the multiple resources, how we have actually multiplied our capacity building even in the districts. So what we have done is we have got the required support from the state health agency, and even the CEO sir was very much in line with this idea. So we have initially connected with all the district coordinators and DHOs, that first you start attending those sessions, and then you can replicate it, or you can do the IEC of the same program with the other districts as well, and other resources as well. So since it's a weekly session, and since we don't have any zero additional cost to be paid, like we need not to pay for organizing a program. It is just an online platform. So it is reducing our cost of building capacity as well. Next slide, please. So first, we have started it on 17 May to 2014, and once we have started doing it, we started focusing on specific pointers initially. But since now we have trailblazers even in the district areas, they decide for us that this is supposed to be topic for the next week, and in fact it is working on an autopilot mode. So let's say somebody from the SHA is not available to present the idea, somebody from the district itself is available to present the idea on behalf of SHA. So this is how we are doing it, and what we are doing is we are just enabling the entire workforce to come up on board and start learning through that Gyan Ganga sessions. We have ensured that we kept the session very short for 1 hour, so that it is not a burden for everybody. It is not a long session that you have to sit through the entire session. If you want to do, come up with just a 14-15 minute session, or if you want to learn some particular ideas only, you can attend the session only for 15 minutes. We are not putting any foundation that you have to sit through the entire 1 hour session. And we have increased the stakeholder participation also. We have started coming up with that 10 to 15 minutes open session. Though Q&A can be done at any point in the entire 1 hour session, but we have kept a slot of 15 minutes specifically where we ask them a question, and then there are prize ceremony also, that if you have answered it correctly, then there will be some rewards accordingly. Next slide, please. So as you can see that we have started receiving testimonials also, and we have concluded around 3,000 plus minutes of learning. It's a huge number for us, because initially we were struggling with our capacity building initiatives, and we have held more than 52 Gyan Ganga sessions so far since we have started in 17th May 2014. Till now we have done around 52 plus sessions, and we are organizing another session on Friday 4 to 5. And we are happy to welcome if some participants from the other state wanted to look after how we are rolling out this entire program. Next slide, please. So as you can see that we have increased 13% increase in our Aadhaar card creation, 22% increase in HFR creation. Scan and share has been exceptional for us since we have started dealing with the private stakeholders, and we have asked them that this is what you can also do in your private facilities. We have an astonishing growth of around 613%, and we have increase in the record linking as well. Next slide, please. So basically, the idea is pretty simple. It is easy to adopt. It is sustainable, as I rightly said, that it is in autopilot mode. That even if I'm not there, that somebody else will take the session and it will be rolling out for sure. And it is having a potential that it can be scaled up to the national level as well. Next slide, please. So this is it from our side, and we are happy to take questions if there are any. Thank you. Thank you.
Thank you so much, sir. We will now be opening it up to questions. We can probably take 2 questions for now, and if there are any additional ones, we can probably take it towards the end of the 1 hour session. So yeah, if there are any states who would like to ask a question, you can probably raise your hand and we can take it one by one.
Yeah, good afternoon, sir. Uh, I am from Assam, so thank you for the presentation. I have one query, sir. Whatever the programs has been designed in the portal, so is there any mandate that 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 someone needs to attend it at district level or at sub-center level or at facility level? Is
Well,
there any
that
mandate also there, sir?
well, that's the idea, that if I mended it,
Is
then
there
it will be a
any
burden.
is there any criteria that at district level this number of session uh, have to be attended or something like that?
No, that's the whole point. If I started putting a restriction in an open mic session that only 20 people can attend my open mic session, then I'll be having a limited participation. But if I make it open, that it is an open session, whomsoever wants to attend, whomsoever wants to learn, they can join in, and they can, if they want to present it also, they can present it as well. That's the whole idea about an open mic sessions. And this is the idea behind the Gyan Ganga sessions also. So there is no restriction
Sure.
at all, and multiple
So,
stakeholders are joining the sessions.
yes, sir. And sir, what is the mechanism to upload any content or anything? Suppose who decides that at state level or at ground level also?
See, SHA is the supreme body. Basically, we take a call that we are going to have a session on, let's say, scan and share, or this week's session will be on ABA, this week's session on HPR. But this is just a primary agenda, that this is what we are going to discuss. So in first half an hour, we present our ideas. And if the audience is okay to discuss something else, then the house is open for the rest of the half an hour for some other topics, some other sessions, or maybe we can just simply do quick Q&A for next half an hour as well. It is structured, but it is not completely structured that we are going to talk only about this particular point, because this may not interest the rest of the audience. So let's say if I do it for HPR drives in government hospitals, then I'll only be attracting only the audience from the government side. I will not be able to attract the audience from the private stakeholders. So that is why I keep the session open for the next of the half an hour, so that even the private stakeholders would like to join in and share their ideas and experiences as well.
Thank you.
Sure. Any other questions? I guess there are no other questions, so I would heartily request other state participants also to join our Gyan Ganga session on this Friday from 4 to 5. Thank you.
Okay. Thank you so much, MP. I think if we can move now with Punjab, request the representations from Punjab. Yeah, request the representatives from Punjab to present your case study. Baki sir.
Uh, Very good afternoon, sir. Should we proceed, Punjab?
Yes, sir, please.
Uh, Very respected Vikram Pagaria, sir, Director, National Health, representatives from the states. A very good afternoon to all of you. So, thanks a lot for inviting to this webinar on cross learning for states and union territories. So, I'll start with on a problematic context, problem statement with the state was that traditional IEC channels had limited impact on urban youth and working population. Another issue was low awareness of ABDM and ABHA generation among citizens. And of course, there's a need for mass engaging high visibility awareness platforms. So in the given circumstances and with the, of course, restraint of somewhat funds, I would say, the NHM Punjab along with, I would say, SHA Punjab, we chose certain campaigns, out of which today this webinar we are be talking about the cinema halls as the effective outreach medium, which has seen success in Punjab. So to start with, sir, basically the cinema and movies we know are very deep rooted in our culture, ethos, our society. We have been brought up watching a lot of movies. I would say just not watching movies, but also we've been living movies and making them a part of our lives. So cinema definitely thus plays a big role, and here is what we have capitalized this medium for Punjab. Reason behind this thing. So as they say, you don't need to do different things to be big. You just need to do things differently. So to capitalize this medium of cinema, our team, which is led by Ms. Vasundhara, she is the joint director of the ABDM program here. So we and I've been assisting with Mr. Maninder, who's IEC expert. He'll also pitch in with me in this presentation. So we capitalized the medium of cinema. We realized the potential of this medium, and we did not do anything different. We banked upon a policy, in fact, which was made by Government of India itself, Central Bureau of Communication, formerly known as DAVP. The capacity being very big for this platform, and especially in the given backdrop that the rates being available for the government agencies are nearly 1/10 of the commercial rates. It's a very, very economical uh, platform, very, very economical mode of communication. For those states who haven't tried this, we would really suggest that to try this mode of communication. It's very effective in terms, because especially the special rates available to the governments and their departments. So, and the viewership in Punjab and state, we have a very large viewership of a very high footfall. People, going to cinemas with the new multiplex culture, and the lot of, and this has re-emerged cinemas. We know after few decades of dull, again, this platform has revived, and we have been seeing lot of footfall, lot of people opting for the cinema platform. So, with this, we get uh, privilege of catching the unwavered attention of our audience. Once they are in the cinemas and our advertisement, if we look back, we can recall those who are of some of I would say I'm around 550 of those who are of my age. We remember that Binaka advertisement. We remember the Lux advertisements, which we have. It has a deep impact on our minds watching that in those advertisements in the cinema. So the unwavered attention of our audience, this is the best part which we have. There is no interruption, and compared to the television, there is an interruption. People keep moving. They're not particularly glued to the television, and during advertisements, they get up, leave the place, and then they come back again when the program resumes. So cinema has this advantage. So I'll now pass on to Maninder to exactly explain the Punjab's plan, which we have done, for which we are giving this presentation here on the webinar.
Good afternoon, everyone. So, for implementing this thing in Punjab in the cinema halls, as explained by Shivinder sir, we selected cinema halls, the agency that was empaneled with the Department of Information and Public Relations Punjab, and the rates that were provided were based on DAVP rates, CBOC rates. So, the implementation, the first and foremost thing was to create a video in HD format that was created in a local language, and that was created in Punjabi. We developed the video in Punjabi in the HD format to be used in the cinema halls. And that video was being screened before the movies were started, or during the intervals. And the content was basically ABDM benefits and ABA creation, and to aware people about how ABDM works and how ABA creation, how they do create their ABA numbers, so that we can create a positive environment for ABDM implementation. As we started this campaign last year, and after that we went on to start implementing ABDM in our district level hospitals, and then now we have moved on to sub-regional hospitals as well, and the plan is to move to private facilities. So these type of campaigns have created a positive environment for the rollout of ABDM in Punjab. So this is our actual video. This is in Punjabi. Some of you might not understand it, but this will give you a context. This is 70-second video. So we are playing this for your context, so you can see the video, actual video. Then we'll move forward with the other parts of the PPT.
जस्सी तू अपने परिवार ਦਾ ਆਵਾ ਖਾਤਾ ਬਣਾਇਆ?
ਆਵਾ ਖਾਤਾ ਇਹ ਕਿਹੜਾ ਖਾਤਾ ਹੈ?
ਤੈਨੂੰ ਨਹੀਂ ਪਤਾ?
ਨਹੀਂ।
ਸਰਕਾਰ ਸਿਹਤ ਖੇਤਰ ਵਿੱਚ ਡਿਜੀਟਲ ਸੇਵਾਵਾਂ ਲੈ ਕੇ ਆ ਰਹੀ ਆ।
ਅੱਛਾ।
ਤੇ ਇਹਦਾ ਫਾਇਦਾ ਵੀ ਹਰ ਕੋਈ ਲੈ ਸਕਦਾ। ਬਸ ਤੁਹਾਨੂੰ ਆਪਣੇ ਪਰਿਵਾਰ ਦਾ ਆਵਾ ਜਾਨੀ ਆਯੁਸ਼ਮਾਨ ਭਾਰਤ ਸਿਹਤ ਖਾਤਾ ਬਣਾਉਣਾ ਹੋਵੇਗਾ।
ਵੀਰੇ ਉਹ ਤਾਂ ਠੀਕ ਹੈ, ਇਸ ਆਭਾ ਨਾਲ ਹੋਵੇਗਾ ਕੀ?
ਆਵਾ ਖਾਤਾ ਵਿੱਚ ਤੁਸੀਂ ਆਪਣੇ ਸਿਹਤ ਦੇ ਸਾਰੇ ਡਾਕੂਮੈਂਟ ਸਾਂਭ ਕੇ ਰੱਖ ਸਕਦੇ ਹੋ ਤੇ ਆਪਣੇ ਸਿਹਤ ਪ੍ਰਦਾਤਾ ਨਾਲ ਸਿੱਧੇ ਤੌਰ ਤੇ ਸਾਂਝੇ ਕਰ ਸਕਦੇ ਹੋ।
ਅੱਛਾ, ਇਸ ਦਾ ਮਤਲਬ ਹੈ ਕਿ ਮੈਡੀਕਲ ਰਿਕਾਰਡ ਲੱਭਣ ਅਤੇ ਮੈਡੀਕਲ ਫਾਈਲਾਂ ਸੰਭਾਲਣ ਦੀ ਪਰੇਸ਼ਾਨੀ ਤੋਂ ਛੁਟਕਾਰਾ।
ਤੇ ਹਾਂ ਬਿਲਕੁਲ, ਜੇਕਰ ਟੀਕਾਕਰਨ ਰਿਪੋਰਟ, ਟੈਸਟ ਰਿਪੋਰਟ, ਡਾਕਟਰਾਂ ਦੀਆਂ ਪਰਚੀਆਂ ਇਹ ਸਾਰਾ ਕੁਝ ਤੁਹਾਡੇ ਫੋਨ ਦੇ ਵਿੱਚ ਹੋਵੇਗਾ ਤਾਂ ਕਿੰਨਾ ਆਸਾਨ ਹੋਵੇਗਾ।
ਫੇਰ ਤਾਂ ਵੀਰੇ ਛੇਤੀ ਦੱਸ, ਇਹ ਆਭਾ ਕਿਵੇਂ ਬਣੂਗਾ?
ਇਹ ਬਹੁਤ ਆਸਾਨ ਹੈ। ਤੁਸੀਂ ਆਪਣੇ ਫੋਨ ਦੇ ਵਿੱਚ abdm.gov.in ਖੋਲੋ, ਆਪਣੀ ਜਾਣਕਾਰੀ ਭਰੋ ਤੇ ਤੁਹਾਡਾ ਆਭਾ ਖਾਤਾ ਬਣ ਜਾਵੇਗਾ।
ਮੈਂ ਆਪਣੇ ਪਰਿਵਾਰ ਦਾ ਆਭਾ ਬਣਾ ਲਿਆ ਹੈ। ਤੁਸੀਂ ਵੀ ਆਪਣਾ ਆਭਾ ਬਣਾਓ ਤੇ ਡਿਜੀਟਲ ਹੋ ਜਾਓ।
ਜੱਸੀ,
So this was the actual video that we created for giving information about ABHA creation and what are the benefits of using ABDM. So coming on to outputs, the campaign was rolled out in multiple districts in Punjab. Almost we have covered almost every district in Punjab where PVR or Cinepolis screens were there. More than 70 screens were used for this across the state. We have 23 districts, so on an average every district has 1 to 2 screens, and larger districts got more than 5 6 10 up to 10 screens for this campaign. And the videos were screened before the movies and during the intervals, as already explained. The reach, estimated reach was that we reached almost lakhs of viewers during the campaign. This campaign was launched in August 2024, and during that time, because due to independence time, and there were a lot of movies being released, and the footfall was higher, so the time period of the release was also good for a higher footfall. So our expectation is that we have reached lakhs of viewers during that time. And as most of the movies, youngsters are there, families goes there, professionals goes on for entertainment, so we have reached a different segment of the society. We have created high visibility among youth, among the families and the professionals. Outcomes are after that our ABHA number increased significantly, and we have during that period more than 3 to 4 lakh ABHAs were created in August 2024, and during that period also we started a pilot projects regarding ABDM implementation in a few of the district hospitals across Punjab, and now after almost 8 9 months of that campaign, we are seeing really good scan and share numbers across district hospitals in Punjab, especially the pilot facility at Mohali, which we started after this campaign, and that facility is creating almost 70% plus token generation from the OPD. The 70% of the OPD is being done by scan and share mode only, and it has also helped us create a positive perception for ABDM to be people friendly and easy to use portal for health benefits. Uh, Doing this campaign in cinemas has also waved away the thing. It has also neglected that thing that people were thinking negative about ABDM, that why to scan QR codes, and why we should scan QR codes on our phone. Some people are taking this as
Wave away the misconception.
misconception. We have been able to wave away the misconceptions. So on sustainability and learning, next slide. So the cinema screens campaign is cost effective and it has high impact, as already explained by Shwender sir, that the rates are available to government agencies 1/10 of the commercial rates. We used a local language with local content, and that content was culturally relevant as well. And public-private partnership was strengthened for the outreach. The lesson we have learned that this is a non-traditional IEC channel, and it can accelerate digital health adoption for Punjab and for other states as well, if used well and if used with a proper plan. Next. Thank you. This is from us. So if there is any question, kindly.
Thank you so much, sir. If any states has any questions, we can probably take 1 or 2 questions in consideration for the time.
Yeah, good
If
evening.
not, you
This
can
is
also talk. Yeah,
yeah, good evening. This is Dr.
yeah.
Shweta here from ABDM Goa. We had tried exploring this initiative or approach in 2022 when we had approached INOX to have a similar kind of initiative. But then we were told very high rates then. It was almost for 10 to 15 seconds, we were quoted around close to 1.5 lakh. So we would like to know, I mean, you said because 1/10 rates were offered to you. I mean, how did you go about this? Because in 2022, when we had approached them, I mean, the rates were quite high and they didn't say any concession to any government agency which you have mentioned. So if you could please throw more light on this.
Yes, certainly, but I feel at this point that there is some sort of miscommunication because we follow the Directorate of Audiovisual Publicity at that time in year 2022. This organization works under the Ministry of Information and Broadcasting, Government of India. So rates, they define the rates, and I leave aside more than 1 lakh. It's just for 10 seconds, not even more than 60 rupees for 10 seconds. So this point needs to be clarified. You can talk to CBOC, Central Bureau of Communication, and you can get the and rates are available on the website as well. They have a website.
They can get in touch with their
Right.
own DAP.
Yeah, and you can get in touch with the Department of Information and Public Relations of Goa. They can
Okay,
certainly
yeah.
help you on this.
Yes,
So,
yes,
of
sure.
course, 1.5 lakh for 10 seconds is way too high, and compared to the rupees 60 we are talking about. So it cannot be compared to 1 point. So certainly there's some miscommunication in that.
Yes, thank you so much.
Thank you, Punjab team.
Sir, I have a question. I am Vishal Chug, working as a project manager for ABDM Haryana. So, sir, basically Punjabi is also one of the common language in Haryana also. So, I would like request to the ABDM team Punjab if they will share this video with us. So, we will also promoting this video in our state as well. So I am sharing my email ID in the chat box. So it will be really helpful for us if they are sharing this file in zip format with us. So
Okay, sir.
thank you.
Okay, sir. We'll share the HD file with you.
Yes, please. So I mentioned my email ID, department email ID in the chat box. Please note it down. And thank you in advance.
Okay, sir. Okay.
Thank you,
also
Vishal.
mentioned, just if I can comment. You also mentioned about some empaneled multiplexes. Are there any, I mean, is there any particular empaneled list of multiplexes?
Yes, ma'am. Of course, there are almost all the cinema houses are empaneled. It's sort of a made binding by Government of India. This is the advantage I'm talking about, that it's binding for them. Actually, if we go with the cinema houses, they are not very pleased to run our campaigns because from the commercial, they are getting a lot of far more higher money. But by the virtue of Central Bureau of Outreach Communication, we are getting these concessional rates, which are very low. So we all must take the advantage of this scenario. So all the major players, let me answer again. It's all the major players like PVR, which is Priya Village Roadshows, PVR, and then Cinepolis, and then Inox. Inox. So all of them are there. They are inside. They are part of this, and they have to follow the rates. Thank you.
Thank you so much.
Thank you, Punjab team. So moving ahead, since if any state is not having any further question, I believe. If no, then we can move ahead with other states. Karnataka. Okay. Since Dr. Vasant is not available now, we request Rajasthan team to kindly go ahead with your presentation. Rajasthan team.
Good afternoon, team. Good afternoon, all of you.
Good afternoon, Rajasthan. Could you please start with your presentation?
Hello, good afternoon, all. Is my screen visible to all?
Yeah. It is visible. You can expand it, enlarge it a little bit.
Is it okay now?
Yeah, perfect.
We have, first of all, thank you for this great opportunity. The state of Rajasthan had initiated an idea that how to create EHR for the public, which is Aadhaar linked or in line with ABDM. So as the state was facing the inertia factor from doctors, so we came with an idea that how can we create an EHR of a patient which visits hospital and doctor writes offline prescription or and rest the operators do the rest things. Then हमने सोचा कि कैसे ये हम पेशेंट्स का EHR बनाएं कि जो भी सिचुएशन है उससे हम चेंज भी ना करें, ग्राउंड पे जो हेल्थ केयर प्रोफेशनल्स हैं उनको ना छेड़ा जाए और EHR कैसे बनाया जाए। तो जो हमारे पास में जो एक चैलेंज था वो चैलेंज यही था कि इनकम्प्लीट और नो हेल्थ रिकॉर्ड था और वो डिस्ट्रीब्यूटेड था अलग अलग प्लेटफॉर्म पे और फ्रेगमेंटेड सॉफ्टवेयर्स थे। जैसे एक DVDMS सॉफ्टवेयर है, ड्रग एंड वैक्सीन डिस्ट्रीब्यूशन मैनेजमेंट सिस्टम, जो हमारे यहाँ पे CDEC का EOSD सॉफ्टवेयर था जिसमें हम ड्रग डिस्पेंसेशन की एंट्री किया करते हैं, जो कि अब तक इम्प्लीमेंटेड था PHC लेवल तक। और एक जो हमारा जो HMIS है, हमारा स्टेट का खुद का HMIS है, वो है IHMS कहते हैं हम उसे। उस पे पेशेंट का OPD रजिस्ट्रेशन, क्लिनिकल सर्विसेज, डॉक्टर डेस्क वगैरह सभी मॉड्यूल्स अवेलेबल थे। बट डॉक्टर्स और जो हेल्थ केयर प्रोफेशनल्स थे वो इन सब मॉड्यूल्स को यूज नहीं किया करते थे। तो हम लोगों ने ये चैलेंज फेस किया और EHR क्रिएट करने के लिए, और जो हमारा एक स्टेट बजट अनाउंसमेंट भी था कि जिसको हम कहते हैं राजस्थान डिजिटल हेल्थ मिशन, जो कि ABDM के लाइन पर ही था। तो उसका मैंडेट कंप्लीट करने के लिए हमने ये पॉलिसी पुश किया कि जो भी मेडिकेशन एंट्री हो रही है सॉफ्टवेयर में,
हम बस अपने आप को प्रमोट नहीं कर रहे, शो ऑफ नहीं मार रहे।
हेलो, इज देयर एनी क्वेरी?
No, you can go ahead.
Okay. तो जो IHMS में जो फार्मेसी की एंट्री हो नहीं रही थी उसके लिए एक सेपरेट सॉफ्टवेयर था, तो और वो ABDM कंप्लाइंट नहीं था, तो इसके लिए हमारा जो IHMS ABDM कंप्लाइंट हो गया। उसी के साथ ही हमने फिर जो उसका फार्मेसी मॉड्यूल जो एग्जिस्टिंग था, अनयूटिलाइज था, उसको यूज करने के लिए हमने पॉलिसी पुश किया और उसके लिए हमने डायरेक्शंस इशू करवाए। तो जो विजन है हमारा IHMS फार्मेसी मॉड्यूल का, जो डिजिटल हेल्थ के लिए, इसमें जो एक कंप्लीट हेल्थ रिकॉर्ड क्रिएट करना था, जो कि हो रहा था। और अब हेल्थ रिकॉर्ड में हमने जो फिजिकल स्लिप्स और जो फ्रेगमेंटेड इंफॉर्मेशन थी, उसको कंप्लीट एक पार्शियल हेल्थ रिकॉर्ड क्रिएट करने की तरफ हम लोग गए, और जो कि PHR ऐप से भी एक्सेस हो सके और एक स्ट्रीमलाइन रिट्राइवल हो सके। तो हमने हमारा जो IHMS जो ऑलरेडी M3 कंप्लायंट सॉफ्टवेयर का था, उसका फार्मेसी मॉड्यूल को रोल आउट किया, जिससे कि जो हमारा EOSD के जो कि हमारी ABDM में EHR के पार्ट पे जो भी लिमिटेशंस थी, वो हमने हटाई और उसको हमने इंटीग्रेशन पे काम किया। उसका जो स्कोप लिमिटेड था, उसको हमने और आगे बढ़ाया। EHR क्रिएट नहीं हो रहा था, वो हम लोग आगे गए, और इंटीग्रेशन नहीं था तो हमने उसको IHMS पे हम लोगों ने रोल आउट कर दिया। तो इससे हमारा ऑटोमेटेड EHR बना, आभा से ऑलरेडी इंटीग्रेशन हो गया। पेशेंट और जो होलिस्टिक इकोसिस्टम के पार्ट पे स्टेट ऑफ राजस्थान ने यूनिक अप्रोच अपनाई। वो ये थी कि हमारे पास में यहाँ पे एक स्टेट का डेमोग्राफिक डेटाबेस अवेलेबल है, जिसमें eKYC डेटा ऑलरेडी अवेलेबल है, और वो जो हमारा IHMS है उस डेटाबेस से इंटीग्रेटेड है, जिसको हम लोग कहते हैं जन आधार, जिसमें हर नागरिक की, हर सिटीजन की eKYC बेस्ड इंफॉर्मेशन है, डेमोग्राफिक इंफॉर्मेशन है, बायोमेट्रिक इंफॉर्मेशन है। तो ये हम लोगों ने इसको IHMS से इंटीग्रेट कर दिया। बिफोर ABDM, जब ABDM एग्जिस्टेंस में आया, उससे पहले हमारे यहाँ पे IHMS जनाधार के साथ में इंटीग्रेटेड था, और जो स्कैन एंड शेयर का एक पार्ट था, जिसमें डेटा डीडुप्लीकेशन ना हो, डेटा की यूनिकनेस बनी रहे, वो हम लोग जनाधार ID हम लोग मांगते थे OPD काउंटर्स पे, और उसके बिहाफ पे डेटा प्री पॉपुलेट होके आया करता है। अब हमने चूंकि इसको ABDM कंप्लायंट कर लिया है, तो हमारा जो आभा की जो एक ID की मैपिंग जनाधार ID के साथ में भी एग्जिस्ट करती है। तो इससे हमें जो एक और एडवांटेज मिला, वो ये मिला कि काफी सारे हमारी एप्लीकेशंस हैं जो स्टेट स्पेसिफिक है और जनाधार से इंटीग्रेटेड हैं। और जैसे ही वो आधार से, क्योंकि जनाधार से डेटा पुश होता है और उसके अगेंस्ट में एक आभा ID क्रिएट होती है, तो जो भी आभा ID क्रिएट होती है, हम उनको जनाधार डेटाबेस में भी पुश कर पाते हैं, और एक मैपिंग हमारे पास में रहती है। तो एक डीडुप्लीकेसी और एक एक्स्ट्रा एफर्ट से हम लोगों के पास में टाइम सेविंग रहता है, और एक इफेक्टिव मैनर में हमारे पास में, चाहे से वो पेशेंट आभा के साथ में आ रहा है, जनाधार ID के साथ में आ रहा है, या आधार के साथ में आ रहा है, या जो लोकल HID है उसके साथ में आ रहा है, ये हमारा सॉफ्टवेयर इंटरऑपरेबल काम करता है। गाइडिंग अप्रोच ये रही है, जैसे मैंने बताया कि जो स्टेट बजट अनाउंसमेंट था EHR क्रिएट करने के लिए, RDHM और ABDM ने EHR का मैंडेट करा PHC लेवल तक, और EOSD की साथ में जो गैप्स थे वो हमने आइडेंटिफाई करे, और जो इंटीग्रेशन पे हमने एम्फेसाइज किया कि EOSD का IHMS से इंटीग्रेशन कर देते हैं, जो कंप्लीट हो चुका है। थोड़े बहुत कुछ टीदिंग इश्यूज आ रहे हैं, जिसको हम अभी कंप्लीट रोल आउट नहीं कर पाए हैं। अभी तक हमने जो इसका रोल आउट किया है, वो है सभी DH तक हमने इसका रोल आउट कर दिया, और इससे काफी अच्छे रिजल्ट्स भी हम लोगों ने देखे। थोड़े बहुत कुछ गैप्स हैं, जिसके ऊपर अभी हमारी टीम और जो डिपार्टमेंट ऑफ IT है, जो कि हमारा जो IHMS है, उसके ऊपर काम करती है। दोनों के साथ में हम अभी कोऑर्डिनेटेड एफर्ट्स के साथ में काम कर रहे हैं। तो जो लीडरशिप सपोर्ट हमें मिला, वो हमारे सेक्रेटरी मैडम से, उनसे हमने एक ऑफिस ऑर्डर इशू करवा लिया, और DYT से हमने टेक्निकल सपोर्ट लिया, जिसके बाद में हमने जो फील्ड में PMOs हैं, CMHOs हैं, उनको हमने ऑप्टिमली, उसके बाद में हमने कॉम्पिटेंट लेवल से डायरेक्शंस इशू कराए। काफी सारी हमने VCs कराई, कैपेसिटी बिल्डिंग करवाई। जो भी ऑपरेटर्स थे, उनको हमने नया सॉफ्टवेयर यूज करने के लिए जो स्क्रीन थे, इंटीग्रेशन था, जो भी उनकी कॉन्फ़िगरेशन करना था, उसके लिए हमने कॉम्प्रिहेंसिव VC सेशंस ऑर्गेनाइज किए। और जो रिसोर्स की बात करें तो फाइनेंशियल जो थे वो ऑलरेडी हमारे कुछ स्टेट बजट अनाउंसमेंट का पार्ट था। RDHM हमने कुछ इससे लिया और कैपेसिटी बिल्डिंग के लिए हमने ABDM CB फंड्स यूज किए। अभी भी हम लोग नॉर्मली हर वीकेंड एक वर्कशॉप हमारे स्टेट इंस्टीट्यूट ऑफ हेल्थ एंड फैमिली वेलफेयर में ऑर्गेनाइज किया करते हैं, जिसमें काफी सारे वेरियस स्टेक होल्डर्स, हमारे जो IT के हेल्थ केयर प्रोफेशनल्स हैं IT के, हम उनकी वर्कशॉप्स रखते हैं। जो भी और अदर डॉक्टर्स हैं, PCPNDT एक्ट में जो लैब्स रजिस्टर्ड हैं, उनको हम लोग इस एक्टिविटी के लिए हम लोग बार बार कॉल करते हैं। और जो हमारा जो इंस्टीट्यूशनल जो IHMS है, उसके साथ में अभी जो EOSD में इंटीग्रेशन हो गया है, और जो फैसिलिटी लेवल पे अब जो भी ड्रग्स हैं वो हम IHMS के फार्मेसी मॉड्यूल से डिस्पेंस करते हैं। और जो नॉन फाइनेंशियल पार्ट पे रहा, NHA ने हमें जो PHR एप्लीकेशंस के जो भी काफी सारे वेंडर्स थे, उनके सपोर्ट लेने के लिए भी कहा था। तो हमने उनको एक स्टेट लेवल पे हम लोगों ने VC करी और हमने उनसे सपोर्ट प्लेस करवाया। तो काफी सारे जो उनकी तरफ से जो इनिशिएटिव्स आए, जो लोग चाह रहे थे कि हम स्टेट ऑफ राजस्थान को हेल्प करें, तो हमने उनकी हेल्प ली। और हमने ऑलमोस्ट सभी DH और SDH जिनकी OPD 1000 से अबव है, वो ऐसी हेल्थ फैसिलिटीज हमने उनको स्कैन एंड शेयर यूज करने के लिए दी है। और साथ में हमने उनको ये भी कहा है कि वो आभा के साथ में और इस तरह की कैसे वो अपना PHR ऐप को और हेल्थ रिकॉर्ड को एक्सेस कर सकते हैं IHMS में। और जो इम्प्लीमेंटेशन पार्ट पे रहा है, जैसे मैंने कहा कि हमने गैप आइडेंटिफाई करा और हमने HR बजट और DYT के साथ में कोलैबोरेशन किया। IHMS के साथ में हमने EOSD का इंटीग्रेशन करवाया, हेल्थ रिकॉर्ड लिंकेजेस करवाए। और जो पायलट हमने किया, हमारे DH है, हमारा एक दौसा हॉस्पिटल है, एक SDH हॉस्पिटल था, हमने उस पे पायलट किया और काफी अच्छे रिजल्ट्स पाए। और एक हॉस्पिटल था SMS, उसके ऊपर पहले से ही वो चीजें ऑलरेडी थी, लेकिन वो ME के अंडर में था, तो कुछ एडमिनिस्ट्रेटिव इश्यूज थे। तो हमने MH के अंडर में जो हमारे एडमिनिस्ट्रेटिव कंट्रोल के हॉस्पिटल्स थे, उनमें हमने ये पायलट टेस्ट किया, यूजर फीडबैक लिया, देखा कि कैसे कहीं पे ग्लिचेस तो नहीं है, खुद टेस्ट करे कहीं पे, जो एक फीडबैक लूप एस्टेब्लिश किया। और जो भी फीडबैक आया हमने टेक्निकल टीम इसके साथ में शेयर किया और काफी अच्छे रिजल्ट्स आए। और जो प्रॉब्लम जो हमारा जो कहीं पे पहले के EOSD सॉफ्टवेयर में कहीं पे स्टॉक का गैप था, और चूंकि साइलोज में सॉफ्टवेयर थे, एक हॉस्पिटल में 3 सॉफ्टवेयर यूज हो रहे थे कि जो एक पेशेंट आ रहा था तो उसका रजिस्ट्रेशन IHMS में हो रहा है, ड्रग डिस्ट्रीब्यूशन EOSD में हो रहा है, और अगर कोई प्रेग्नेंट लेडी आती है तो उसका रजिस्ट्रेशन एक प्रेगनेंसी चाइल्ड ट्रैकिंग सॉफ्टवेयर में होता है। तो इस तरह के हमने 2 सॉफ्टवेयर तो खत्म कर दिए, अभी एक ही सॉफ्टवेयर पे काम हो रहा है। PCTS पे अभी हमारा उसका इंटीग्रेशन पे काम हो रहा है, जल्दी वो भी M2 इंटीग्रेशन हो जाएगा और वो IHMS के साथ में एक सिंगल स्क्रीन के साथ में हम हमारे हॉस्पिटल्स में वो शेयर कर पाएंगे। और अभी जो हमारा जो स्केल है, जो हम एक्सपेक्ट करते हैं कि हमारी 1500 प्लस हेल्थ फैसिलिटीज पे हम इसको रोल आउट करना चाह रहे हैं, जिसमें सभी PHC लेवल तक, एज पर स्टेट बजट अनाउंसमेंट, सभी का PHC लेवल तक EHR क्रिएट हो सके। अभी तक जो हमारा एक्सटेंसिव कवरेज रहा है स्टेट में, फार्मेसी मॉड्यूल का अभी तक हमने 150 प्लस हेल्थ फैसिलिटीज में ये लाइव कर दिया है। जैसे मैंने बताया कि कुछ टीदिंग इश्यूज आते हैं सॉफ्टवेयर में इंटीग्रेशन के बाद में, तो अभी हम उसको फिक्स कर रहे हैं और फीडबैक लूप के थ्रू हम उसको इन इश्यूज को रिजॉल्व भी करवा रहे हैं। तो ये बाइफर्केशन दिया है कि जिसमें 26 हेल्थ फैसिलिटी ME मेडिकल एजुकेशन के अंडर में भी हैं, जो कि इसके थ्रू काम कर रही हैं। ये एक ट्रेंड है, जब से हमने EHR के ऊपर काम किया, मई जून पे हमने इसको जोरों शोरों से काम किया था। और
विष्णु जी,
EHR के नंबर जी,
ये मेडिकल हेल्थ डाइवर्स फैसिलिटीज क्या है? अब पिछली स्लाइड में
ये वाला
हाँ 127
एक्चुअली में हमारे यहाँ पे स्टेट में MH और ME 2 अलग अलग अभी एंटिटीज हैं, क्योंकि इनके एडमिनिस्ट्रेटर्स अलग अलग हैं। तो इनमें जो ME के डायरेक्ट कंट्रोल में है वो 26 हेल्थ फैसिलिटी है, और जो MH के डायरेक्ट कंट्रोल में है वो 127 हेल्थ फैसिलिटीज हैं, और इसी का ही जो DH है वो इसी 127 का पार्ट है। तो अभी हमारे जो अराउंड 70 DH हैं जो हमने इसको कवर कर लिया फर्स्ट फेज में, और अभी हम नेक्स्ट फेज में जो हमारे SDH हैं और CHC हैं और SH हैं, हम उनके ऊपर रोल आउट करेंगे। लेकिन उससे पहले जो छोटे मोटे जो टीदिंग इश्यूज आ रहे हैं हम उसको रिजॉल्व करवा रहे हैं। वो रिजॉल्व होने के बाद में जो हमारे EHR के नंबर हैं वो और स्पाइक कर जाएंगे। और मैं जो अभी इस ट्रेंड पे आ रहा था, जून तक हमने इसको काफी फॉलोअप किया था, और बाद में जब फील्ड से टीदिंग इश्यूज आए तो हमने उसके ऊपर अभी काम कर रहे हैं। वो रिजॉल्व हो जाने के बाद में जैसे मैंने कहा कि अभी SDH SH पे हम फेज 2 में हम इसको रोल आउट करेंगे, तो हमारे जो EHR का पार्ट है वो और एक्सेलरेट करेगा। फिर हम CHC और PHC तक आ जाएंगे। तो हमारा जो भी जो हमारा पेशेंट का जो मेडिकेशन का रिपोर्ट है वो हम EHR का पार्ट बना लेंगे। और इसके थ्रू जो अभी तक जो हमारा एफर्ट रहा है, कैपेसिटी बिल्डिंग में हमने जो ऑपरेटर्स हैं जो पहले EOSD पे काम करते थे, अब ड्रग डिस्ट्रीब्यूशन के लिए 2500 प्लस ऑपरेटर्स हैं, और जो हमारे डिपार्टमेंट ऑफ IT के जो IT प्रोफेशनल्स हैं उनको हमने ट्रेन किया, वो हमारे एडमिनिस्ट्रेटिव ऑफिसेज में है। तो इस चीज की कंट्रोलिंग मॉनिटरिंग के लिए हमने उनको भी ट्रेन किया है, वीडियो शेयर करे हैं, यूजर मैनुअल शेयर करे हैं कि कैसे करना है। और रोल आउट सपोर्ट के लिए ये अभी तक जो 1100 प्लस हेल्थ फैसिलिटी जो MH में है, और ओवरऑल PHC तक हम बाद में इसको 1500 हेल्थ फैसिलिटी तक हम इसको लेके जाएंगे। और इसके लिए हमने हेल्प डेस्क सपोर्ट भी एस्टेब्लिश करा हुआ है, पायलट टेस्ट हम लोगों ने किया हुआ है। और इसके जो अभी एक जो नंबर्स हैं, इस अप्रोच के थ्रू जो अभी तक हमारा जो मैं ये आभा लिंक EHR में केवल IHMS की बात कर रहा हूँ, जो हमारा HMIS स्टेट स्पेसिफिक IHMS है, अभी तक 28 लाख आभा लिंक EHR क्रिएट हुए हैं, जिसमें से 21 लाख जो हैं इस अप्रोच के थ्रू हमने EHR क्रिएट करवाया है जो कि आभा लिंक है। और जो का रिमेनिंग हेल्थ रिकॉर्ड है वो हमारा लैब रिपोर्ट्स है। लैब रिपोर्ट्स भी हमारा अभी काफी हाइक करने वाला है, क्योंकि अभी हमारा एक हब एंड स्पोक मॉडल है, वो हम एक अलग मॉड्यूल में हम उसको टेकअप कर लेंगे। तो अभी तक हमने ABDM की स्पिरिट में और RDHM की स्पिरिट में इस अप्रोच के थ्रू हमने 2.13 मिलियन आभा लिंक हेल्थ रिकॉर्ड क्रिएट करा है। और इसके अलावा EHR तो काफी कुछ है, लेकिन आभा अभी इतनों के साथ में है। स्टेट से हमने अभी एक और एडमिनिस्ट्रेटिव ऑर्डर पास किया है, जिसमें हमने उनको कहा है कि जो भी पेशेंट OPD काउंटर पे आते हैं उनको आप आभा ID लाने के लिए एनकरेज करें। तो अभी उसके ऊपर काम चल रहा है, काफी अच्छे रिजल्ट्स आएंगे, काफी अच्छा अभी तक काम हुआ है, टीम और एफर्ट कर रही है। तो जो हमारे IHMS के जो फार्मेसी इस इनिशिएटिव की वजह से ऑलमोस्ट 75% जो EHR है, आभा लिंक EHR, वो इस अप्रोच से क्रिएट करा है। और ये कुछ हमारा हॉस्पिटल्स हैं जो हमने कुछ रिकॉर्ड शेयर करा है। और जो आउटकम्स है, इम्पैक्ट है, वो ये है कि पेशेंट्स अभी इस जो क्या ड्रग डिस्पेंसिंग है ये इस पार्शियल EHR को एक्सेस कर पाते हैं। और इसमें ऑपरेशन की एफिशिएंसी भी बढ़ी है, क्योंकि हमने अभी तक कुछ जगह पायलट किया है कि जहाँ पे डॉक्टर खुद ई प्रिस्क्रिप्शन भी लिख रहे हैं। तो इनको सेम सॉफ्टवेयर में होने से फायदा हो रहा है कि एक सिंपल एक ऑर्डर बंडल बन के जाता है, और जो MNDY ऑपरेटर है उस ऑपरेटर के पास में सीधे उसको एक सिंगल क्लिक पे डिस्पेंस करना होता है। इससे पहले उनको सेपरेट एंट्री करनी होती थी, सेपरेट सॉफ्टवेयर पे उसकी इनवॉइस करनी होती थी। तो काफी सारा जो एडमिनिस्ट्रेटिव हर्डल और जो डुप्लीकेशन ऑफ एफर्ट हो रहा था वो काफी रिजॉल्व हो गया। और जो एक्सपीरियंस है इसमें काफी इम्प्रूव भी रहा है। और इसके साथ में हमने काफी IEC भी करी और वीडियोस भी शेयर करे, हमने कुछ AI इनिशिएटिव भी यूज लिए RDHM के लिए। मैं चाहूंगा कि RDHM का एक वीडियो भी जो हमने AI से शेयर करा, और IHMS कैसे EHR के लिए हमने एनकरेज किया है, और कुछ इनिशिएटिव लेके हमारे स्टेट में कुछ वीडियो वॉल्स लगी हैं पंचायत समिति स्तर तक, जहां तक हाई फुटफॉल रहता है। तो वो नो कॉस्ट बेस पे हम जो हमारे आईईसी वीडियोज है वो हम शेयर करते हैं, उससे काफी अच्छा एक्सपीरियंस रहा है, एक अडॉप्शन मिलता है हमें। तो जो सस्टेनेबिलिटी की बात करूं तो जो इसका बजट है वो हमें RDHM से भी मिला है, ABDM के जो रिलेवेंट हेड्स हैं हमने उनको यूज किया है, ऑनरशिप ली है उसकी, और जो इंटीग्रेशन किया है 2 सॉफ्टवेयर का, और अभी IHMS का एक 2.0 के ऊपर भी हम काम कर रहे हैं, तो जिसमें एक वास्ट लेवल का इंटीग्रेशन और एक सिंगल सॉफ्टवेयर अप्रोच के साथ में हम काम कर रहे हैं स्टेट पे, तो उसका एक सेपरेट काम हो रहा है उसके ऊपर। तो पार्शियली EHR के तौर पे अभी हमने स्टेट पे इसके ऊपर काम कर रहे हैं। काफी अच्छा EHR का इस पे पोटेंशियल रहेगा, जब तक डॉक्टर्स खुद ई-प्रिस्क्रिप्शन के लिए एग्री नहीं हो जाते, विल नहीं क्रिएट हो जाती, तब तक हमारा EHR इस अप्रोच के साथ में आगे बढ़ रहा है। और इसको सस्टेन करने के लिए हम लोग रेगुलर VC रख रहे हैं, इन पर्सन कैपेसिटी बिल्डिंग सेशन रख रहे हैं, और दोनों टीम्स हैं DYT की और जो CDEC की टीम है उनके साथ में कोऑर्डिनेटेड एफर्ट्स कर रहे हैं, और जो इंटीग्रेशन, एक लार्जर इंटीग्रेशन की बात कर रहे हैं हम, और जो पायलट है उनको और स्ट्रॉन्ग कर रहे हैं, और फीडबैक लूप को और हम स्ट्रॉन्ग कर रहे हैं। ये कुछ एक अप्रोच है जिसके साथ में हम जैसे वो पेशेंट अभी पर्ची लेके आ रहा है, क्योंकि अभी पर्ची के साथ काम हो रहा है, और पर्ची के साथ में उसी सॉफ्टवेयर में उसकी एंट्री हो रही है, और पेशेंट को हम उसका EHR वो ऐप से एक्सेस कर पाए, लैब रिपोर्ट्स ले पाए, उसके लिए हम एनकरेज कर रहे हैं। थैंक यू। तो मैं सेशन फ्लोर ऑन करूंगा कि किसी की कोई क्वेरी हो तो वो पूछ सकता है। थैंक यू।
Thank you, Vishnu ji, for wonderful presentation. So the floor is open for question.
Yeah, thank you, sir, from Rajasthan. I am from Assam, so I have 2-3 queries in regard to the presentation what you have shown. Number one is DVDMS. This application is from CDEC. So I want to know whether your IHMS HMS application has integrated DVDMS into your pharmacy module.
Yes, actually, the DVDMS application is integrated with our eOshdi. Actually, the developer is same, the CDEC, and the state of Rajasthan was one of the first states to implement the approach via eOshdi software, and this approach was replicated by later on, and this application is still there, and we have integrated in a manner that the part of the part which handles medication dispensation within hospital premises, that we have taken in our IHMS. Rest the inventory part we have it is already with the eOshdi. Both softwares are there, but we have taken that was required for EHR creation.
That means whatever data is entered in your IHMS, it automatically fetched to DVDMS also, or the operator needs to enter same data twice in 2 different applications?
Actually, the larger inventory lies with DVDMS or eOshdi, and the DVDMS or eOshdi software allots the stock to the hospital store, and the hospital stores subsequently share the data with our IHMS store of that hospital, and the latter individual dispensation record, IHMS maintains individual store level information, and then it shares the report with the eOshdi that the stock which it has already requested, it has exhausted, or it request or it raise indent to eOshdi software only. And मतलब जो हमने किया है कि जो हॉस्पिटल लेवल पे IHMS की स्क्रीन यूज हो रही है, और IHMS पे जो एक पेशेंट की जर्नी है वो उसके EHR पे खत्म हो रही है। बाकी जो इन्वेंट्री का काम है, इंडेंट का काम है, वो अभी भी DVDMS और EOSD पे हो रहा है।
That means data IHMS से DVDMS में जा रहा है to maintain to update the inventory. That integration is already done. So that API is shared to IHMS from DVDMS because CDAC is commonly developed both the application. Is it like that?
No, actually, we directly do not use a DVDMS application. We have our state-specific application, EOSD, and we have our ownership and full control over it. So we have requested the API documentation, or we have link for our current requirement to create EHR.
Okay. Now this IHMS, what I could understand during your presentation, is an HMIS which is implemented in many health facilities of Rajasthan. Now, this is developed from the funding of development and implementation, because this implementation will require a good amount of infrastructure in the health facilities and few set of IT operator also. So from which fund your state has managed that?
Actually, the state has its IT department, which is implementing various e-governance schemes across various departments, including health. And the Department of IT asked the state government. The state has funded the state HMIS and the EOSD also. So the state is working on an approach कि सारे जो स्टेट स्पेसिफिक एप्लीकेशंस हैं डेटा स्टेट के पास में रहें, गवर्नमेंट ऑफ इंडिया को जो भी डेटा रिक्वायर्ड है वो हम API के थ्रू शेयर करें, डेटा की जो ओनरशिप है वो स्टेट के पास में रहे। एंड एक और इम्पोर्टेंट बात है कि राजस्थान इज वन ऑफ द स्टेट्स which has its own state-of-the-art tier 3 level data center. So these infrastructure requirements can cater in that only. So all over the state-specific applications are hosted on that state data center efficiently, and the state is also asking other states that state data center can earn a revenue from other states also, if other states are willing to host their applications in or a data center. I hope I am clear to I have cleared your query.
Thank you.
Okay, thank you, team. So is there any more questions?
Team, this is Gagan. I don't have any questions. I represent Sandbox integration team, So one request is that, and update also, that I have posted this one WhatsApp chat group link in the chat. So all those active indicators who are still on the Sandbox, please do join, because we are conducting M1, M2, and M3 development session on weekly basis. And we are posting the links through emails as well as on the chat group. So kindly do utilize those kind of sessions, virtual sessions, for quick development and quick turnaround time for the issues. So in case someone is not aware, so I thought I should share with all of you. With that, thank you for your attention. That's all from my side.
Yeah, thank you, Gagan.
Gagan sir, one query I have. Like one of the fresh organization wants to implement the ABDM HMIS. So shall we share this link to those also?
Okay, so the audience for this will be primarily all those entities or the integrators who have been approved by the sandbox, like who have got their client ID. So those are welcome to join this group, because otherwise it is purely for the ABDM integration part, right? So anyone who has got registrations are welcome for this.
If someone is not aware like how to get enrolled in this sandbox, so what exactly the procedure, because they are doing some
Vishal,
hit and track method. Okay,
yeah,
sir.
sorry to interrupt.
So
So
I
we can
personally
have
connect
the
with Gagan.
individual questions.
Sure.
Yeah, you can connect with Gagan. So here, MP has raised the hand. Do you have any query regarding the previous presentation? SHA MP?
Hello, sir. Just out of curiosity, just wanted to know, since supply chain is having multiple functions such as forecasting, indenting, and then the drug distributed from the DDC counter. So how the software is capturing those information, and are they aligned with the ABDM compliance as well? I mean, if somebody can answer it from the Rajasthan side.
Yeah, hi, this is Pinky from Rajasthan ABDM PMU. As you rightly said, that e-Aushadhi bears all the pressure of supply chain and it manages all these things. So we have just done the partial integration with the existing e-Aushadhi with IHMS. So IHMS, only the prescription is getting entered into the pharmacy module of IHMS, and then it is going to the supply chain, the drug dispensing of e-Aushadhi. Apart from that, all these things of supply chain and indenting and managing all the things are to be managed by e-Aushadhi only. So the duplication of entering the prescriptions into the e-Aushadhi and then at the same time in IHMS has got resolved by doing this partial integration. With that, we are also generating health records, and they are linked with the ABA, and then it automatically goes into the e-Aushadhi software. So rest of the things are being taken care of with e-Aushadhi, but then only the prescription things are being entered into IHMS.
So for the inventory management, there is no manual intervention required. It is
No.
okay.
No. It is automatically going into the drug dispensing part is being taken care by IHMS, and rest of the things are indenting and all are being managed by e-Aushadhi.
And how we are managing the drug dispensing at the DDC counter? Is there any barcode based system to track the dispensing?
Yes, actually we have our Mukhyamantri Nishulk Dawa Vitran Yojana, this free drug distribution in Rajasthan from since 2013. So
Okay.
we already have our developed e-Aushadhi since then, and then it's being taken care by the barcode system.
Okay, fair enough. Thank you.
Thank you, team. So now I would request Karnataka team, Dr. Vashant, to please present you.
Yeah, Saurabh, thank you.
Good to see you, sir. We were hoping that we were expecting you here, but somehow the team could not reach here.
Yeah. We have got busy, like it's a transfer time in Karnataka, so we are completely occupied.
Yeah.
Okay, thank you. Thanks
We
for it.
understand. Thank you.
I'm going to share my screen. I'm permitted for that. So in Karnataka, we have done a lot of things, but what the important thing at the present, we feel that our clinical decision support system, which is supported by one of our private partners, should be a need of the hour so that we can take it forward, so that even this people get more, people get the treatment or the screening everywhere whenever they, even before meeting the specialist. In fact, so here, like when to start in 2017, we started this HMS journey, where our Honorable Chief Minister has announced that Karnataka will digitize all its health records in 2017. That's where we lined up with the NIC's e-hospital. But it's already been 8 years, 8 years, but still we come up with a lot of challenges. So one of the main thing is we minimal use of clinical modules by the professionals. Then the on-ground support is always on demand. Then the frequent downtimes, whenever there's a peak OPD, the downtime happens. Then the integrations are not so easily done. So these are one of main challenges for us. So in 2019, when we started our ABDM, our first SMD, our commissioner sir. So that time in 2020, we thought we'll have a pilot with one of the best people in India, support like suggested by you. So we gave our three big hospitals in Bangalore, the KC General, CV Raman, and also Jayanagar General Hospital, to three of our private partners. So among them, the plus 91, they have been given to handle this digitization process based on the selection criteria for the KC General Hospital. So to have this end-to-end digitalization. Next. We started with our HMS journey there, but we had a lot of camps kind of a thing in most of our secretariat and all. That was also, it was a very good successful thing using their HMIs. It's not only the facility based, even the camp based HMIs was also ready in that time. So then like past 1 year, like since 1 year, we started this AIMS clinical decision support system there, where it's more of an NCD, non-communicable diseases drive, where any patient, we don't take him or her as diabetic directly. Any person who's aged more than 30 years for screening into our clinics, the NCD clinic, it's a pre-screening clinic before getting into our physician OPD. Once the patient enters there, the nurse over there or the intern over there checks the vitals, age, weight, and also the previous this health reports. For example, this HbA1c for this blood sugar levels in the hemoglobin. Then once it is done, then it is entered onto this HMIS, where this CDSS analyzes it. Then it gives up the suggestions and the probable diagnosis and the suggestive treatment. So based on that, the most of the time it has covered some 80 to 90% of that thing what is being done by a doctor specialist. Then based on that, we just facilitate it to a super specialist for any management of complication or just have an overview on it. So this is the process what we follow. So as I said, the data input was the demographics, age, gender, and weight. Then the blood pressure, then blood sugar levels, and the clinical history. How long? What are the things like polyuria, polydipsia, all those things. So all those things we take up. Then we enter onto things where you just click on it or a drop downs will come up. Once it is entered onto this, then the CDSS engine will do analytics based on the protocols given by the AIMS, based on the experience and the patient risk assessment. So then it will come up with a probable diagnosis, treatment plans, alerts. Then the main thing is this lifestyle recommendations. So that also is a common thing from the AIMS. So how did we do this? So the HMS selection. So this viable product complaint HMS was selected. And when it's always the ABDM complaints, then we selected this hospital because we are given other two vendors, the other two hospitals, but this plus 91 has been given to work with the KC General Hospital. NCD clinic was chosen because we thought it's an NCD thing. I don't want to directly get into our physician so that they are burdened. Again, they need to enter a thing, then they need to suggest you of it. But still being a doctor, even we feel whatever the suggestion it is based on my knowledge, skills, or my patient experience, I do go with the best treatment, what I understand. Then finally, it is supported by this AIM-CDSS. Then the training process, because this NCD clinic is what we done there. So the training of nurses and also the interns or the MBBS completed doctors were there. So these training things were done. Then the focus areas, like our junior doctors, diabetes and hypertension screening was the focus areas. Then patient follow-up was ensured based on our the PHR app things. The patient follow-up was ensured. So next slide tells us about how did we implement. So we launched it, the workflow mapping. The first thing is how we map the workflow, who does what and all is the things. Then we trained our doctors, nurses, and the other staff. Then the refinement, like based on this, the customization or what are the alerts which we should be sending through our HMIS app, HMIS, the WhatsApp messages or the SMS thing. Then the integration with our NCD clinic doctors and also the specialist. What are the things our specialists expect before going to them is what we have integrated the things there. Then the main thing is this user-centered approach. all those things, this cross-functional collaboration to ensure this technical alignment, all those things are being supported from technical part. So this is our numbers for last 9 months to 1 year. 3 months, sorry, it's 3 months. 3 months we are seeing around the total footfall is around 5 lakhs. So among them, the 75,000, around 8% of the people coming to our hospitals are being screened. Out of them, some 50,000 were found to be high risk and they have been advised the lifestyle recommendations. Around 22,000 patients were diagnosed to be not diagnosed or found to be a more blood pressure. So they have been screened under that and the treatment was suggested and been treated with our specialist. This diabetes case might be, it should be equal most of the time. So it's only 2,500 is the diabetes case what we found. Might be like they would have gone to our nearby diabetology hospital. That's there. So these are some of the numbers, but the actual difference is the standard consultation time. If I supposed to go meet a physician, it will take usually 5 to 7 minutes after getting my OPD slip. But because of the CDSs, the consultation time has reduced. The consultation time in sense, the efficiency of specialist has been increased. Around 2 to 3 minutes per patient. If the specialist is looking after 50, 60 patients, so somewhere around 1 to 2 hours of his specialist time has been saved. And we can, it's not more about pushing the patients, it's about qualitative things being done for them by the facilitation of this MCDSS. So the NCD users, like in our NCD clinic, we have made 8 as NCD users and around 35 personnel, health personnel, doctors and nurses were trained in this. So the future implementation plan, as you are aware, like we are started this piloting. We are called for EY, expression of interest across Karnataka. In the first phase, we have selected 4 private partners are supporting us. One is Plus 91, True Care, then Intro Labs, then the Medimaze. So all these people have been given our district, Taluk and CHCs in a district. So we want to extend it across the state for these 4 pilot locations first. Then we want to integrate this with all the digital solution partners of us because we are coming up with one more UI in another 3-4 days. So we'll have some more private partners with us. We want to integrate that. Then we have e-Shushruth. We are also taken a support of e-Shushruth Live in around 20-30 UPHCs across Karnataka. So it's already being live. Training is done live, and we already started doing the scan and share and started entering on the grid. When we want to integrate this, because what I feel, this CDSS should be reached out to our health and wellness centers, Ayushman Bharat Digital Mission. Basically, we have only our CHOs who are our BSc nursing graduates in Karnataka, and in a PHCs where we have just finished our MBBS doctors. So where all these complicated cases or any resistant cases are being treated before they go to the Taluk district hospital. So there the plan is to extend it to all our arms, Ayushman Bharat across Karnataka, based on this success. Then that's what. Based on this success, we want to implement it across Karnataka. So as of now, we have completed this pilot in KCG hospital. So next, as of these 4 digital partners are onboarded. Now we are going to integrate it with them. Then e-Shushruth pilot all the PHCs and subset. So this is the screening tool. Whenever a person comes to our NCD clinic, it's an initial screening tool, whether we just find out from the patient about their risk factors, what are their dietary things, what are the signs and symptoms they have. This is a physical interaction. So just you click yes or no for this. Then comes our actual thing. We measure the blood pressure. If they have the previous records of lipid profile or the fasting sugars, all those things, we enter it or we check it and enter it. Once that is done, the submission is done. Once it is done, so based on the previous recordings, whether the blood pressure is high or the blood glucose level is high, even it's a fast pre-prandial or fasting or post-prandial or the HB1AC. Based on that, here we see an example of a patient who has been advised as a diabetic treatment, where this oral hypoglycemic has been advised. Metformin with a dose of 1000 mg. It's a bit high, but still, because of his high blood sugars, that's been advised. And even regarding the blood pressure, that it has suggested that it has hypertension stage 2. So as of now, the lifestyle modification is advised, or it can be like what is suggested is if the BP shoots above this minimum value, then you can start with the other medications. So next it tells about this lifestyle modifications. what is the physical activity you should do, then what is the consumption of salt, is the type of foods you eat, vegetables, fruits, what are you should be avoiding, and all those things. This lifestyle more recommendations is based on the weight, the age, or uh, on the values of the blood pressure and the blood glucose levels. So these are the things whatever CDSS is being done, which obviously is making a difference. In the Karnataka, we are doing a project known as this Gru Arogya, where all our community health officers reach out to each and every house and they screen each and every citizen who is aged more than 30 years. So from there, we want to use this also there, so that as of now the procedure is that whenever you feel like get the higher values, then you should have a consultation through e-Sanjeevani. But most of the time, it's the same doctor who need to be available, but the doctors will be busy in the OPD because 30 to 50 OPD is the minimum in Karnataka. So they will be busy. So they will be disturbing them, and most of them they don't pick the call. So I felt this is one of the model where it suggests the treatment there itself. So if it is a mild cases, then the treatment can start there itself using the CDSS. Once it is moderate or severe or a complicated case, then based on the availability of the specialist, they can refer to the taluk or district hospitals for the follow-up. Then after that, the compliance is ensured through the treatment follow-up from my CHOs or the doctors or nurses at the PHC. This is what the plan as of now we have. It looks good for us. And as per our state policies also, we want to screen all our 30-year more aged population and have the proper prevalence in place and implement the policies based on the drugs requirement or the logistics is the plan ahead for us.
Thank you so much, Dr. Vasant. So the floor is open for question. I would ask states if you have any queries, concern, you may ask related to CDSS. I believe they are well satisfied with the slides.
No, this is the future is what I feel, the CDSS. So we need to take it forward for all the citizens across the India.
Actually. So we have been even hearing about CDSS from a very long and have seen.
And sorry to intervene. Then we are also trying out with different pharmacological companies. This is only for NCD care. We are trying out with AstraZeneca for this respiratory disorders. The same thing, and NIC wanted to do it with the these X-rays, like all the system of X-rays, even the accidents, all those things. We have tried it 2 years back, but as of now, this AM CDSS is the benchmark what we have. Very soon we'll have these respiratory things also, so that it makes all our people to screen better and get starting the treatment.
Definitely. So we have our team here as well. If they may have any question, Babita, Bhude, Harshit.
Hi, good afternoon, sir. Babita here.
Babita ji, please tell.
Just a small question. I think we had a discussion yesterday. We had a training for TOTs, and there was one very interesting discussion whether this CDSS is providing inputs in case of different patients, like for a pregnant lady. There are certain medications which cannot be prescribed to them. So is that is being considered and identified under the CDSS, and is it helping in those cases as well?
Good question. So I can answer both as a doctor and also policy maker. So being a doctor, SC, it's always facilitates us to take a decision, better decision, being a doctor. And obviously the inputs are our vital parameters, the age, all those things. As you rightly mentioned that pregnancy is not mentioned here. So, but still the protocol is, being a doctor, I know what are the oral hypoglycemics I should be giving to a pregnant. So it's just suggesting me to have a better treatment. But it's a very good thing what you are told. But if being a policymaker, then we are not focused on. Yes, it should be very good.
Okay. Thank you. Thank you for that.
Dr. Vasant, thank you for a lovely presentation. Just a very small question. You mentioned about how CDSS is helping you efficiently use e-Sanjeevani, and doctors at the hub and spoke in Karnataka are using it to for teleconsultation. Could you please elaborate how that is happening, how the integration between CDSs and e-Sanjeevani has happened, so that other states could learn from it as well? Thank you.
Thing is, see, I expressed the challenge there. Thing is, see, as of now, what we need to do as per this NCD guidelines, any person who's been screened, who has found to be like more values of sugars and blood pressure, once it has been entered onto our NCD portal, then if the CHO decides, or a CHO decides it should be given a consultation with a medical officer or a specialist, then through e-Sanjeevani, they should be reaching out. But most of the time, as the OPD load is high in most of our hospitals, out of 2,500 PHCs, we have 1,000 at 24/7 hospitals. So there, what I felt, instead when our doctors are busy using this CDSs, CHOs itself are more confident, should be more confident in handling the cases. Once they feel, if it is a milder cases, CDSs itself is a very good support system for them. But once it is moderate, severe, or a complicated case, then they will reach out to a specialist who will be available in a taluk and district hospital, but not a medical officer. The specialist at taluk and district hospital, doc level at a district level hospital, they will be available because we have more specialists there. So through them, we can have a consultation and we can elaborate on it. And as Babita ji was also mentioning, when the specific kind of a treatment for a specific personnel comes up, there it makes a difference using e-Sanjeevani. Sorry, your voice is.
If there are
Yeah.
any other questions from any of the states? If not, we can probably close the session for today. So would just like to definitely thank the representatives from the state of Madhya Pradesh, Punjab, Karnataka, and Rajasthan for taking out the time and sort of building out a deck for us, for all of us to learn from basis their case study. Also thanking every participant state that joined here. I know we've extended our time. We said on mail that it would just be for 1 hour. We are here at 1 hour, 30 minutes, but thank you so much for staying with us and sticking with us for an hour and a half. Just a couple of pointers before we close. So from NHA's end, we will be sharing a PPT documentation and a one-pager of everything that was discussed, which would be like the minutes of the meeting or like a short note on what was discussed today. We will also be sharing a feedback form. So because we're planning to now institutionalize this going forward and having it on a monthly basis, we would hope that if you have any ideas on how to sort of think of a different template or a format, we would be open to those ideas. So we'll be sharing this feedback form with you soon, hopefully by tomorrow. Would request all states to please provide us their inputs on that. And lastly, because again, this is going to be a monthly thing that we will institutionalize going forward, we're sort of going to be also launching a expression of interest form, so that states can probably just tell us that this is a specific case study within the states that they would like to sort of display as part of our best practices webinar. And yeah, we'll be hoping to present this on a larger forum such as this. So thank you again. Thank you to all the states that presented today, and thank you for all the states that attended. And we hope to see you soon next month, hopefully at this same time between 3 to 4, not 4:30. Thank you.
Thank you.
Okay, thank you, sir.